Okay, a very good afternoon to everyone, and welcome to our medical department CME today. Now, I know it's we usually have it on Thursday afternoons, but today, due to some scheduling arrangements, so we're having it on a Wednesday. Today's topic will be a cardiology topic, and our presenters will be Dr. Izam and Dr. Kelly Kopp. And we have the privilege and honor of Dr. Suhasini to supervise this session. So for those of you who do not know Dr. Suha, as we commonly call her, she is a cardiology trainee, a cardiology fellow at Hospital Queen Elizabeth II. Okay, so let's see how many, about 30 participants now. So without further ado, I will invite Kelly and Izam to start a presentation. And then if you all have any questions, you can type it in a chat box, and the presenters and Dr. Suha will be able to answer it at the end of the session, or you can also ask at the end of the session. All right, so over to your presenters.
Thank you, Dr. Josiah. Okay. So today, me and Izam are going to present about this topic, heart failure. Then we are supervised by Dr. Suhala, cardiologist. Okay, first we're going to go into one case study. So this patient, Mr. X, age 41 years old, gender is a male, occupation lorry driver. So single and not married. So comorbid-wise, patient is type 2 diabetes, CKD stage 3A, creatinine 138, eGFR 57. He's an ex-Shabu user. Last change was 20 years old ago. So on the first admission to Hospital Kota Belud, he come for fluid overload symptom. Patient presented heart failure symptom for 3 months, which is reduced effort tolerance, optopnia, PND, bilateral lower limb swelling, and scrotal swelling for the past 3 months. He admitted for 2 weeks, then subsequently discharged on the 21st of January. Then in this presentation, he came in the second admission after 2 days in our hospital setting for ADHF. This time we get worsening SOB, bilateral lower limb swelling, and also scrotal swelling for the 2 days after discharge from the hospital Kota Belud. So upon admission, so we assess him. This is a clinical assessment and judgment. GCS E4V5M6. He's orientated to time, place, person, and is warm and wet. So on examination, BP was 107/69, pulse rate is 89. SpO2 is initially need anesthesia prong, so it's 98%. So height is 173 cm, weight is 88.2 kg, and the BMI is 29.5. For him, the MIHA score is 2. He got slightly limitation of physical activities, but still able to do the ordinary physical activities. And CCS class 1. There's he have angina when doing the ordinary physical activities that not cause angina. Okay, then the intermediate score is level 6, assisted limited working wounded. Then investigation that we did for him, this is a white cell count, 6.8.3, HP is 10.5, platelet is 327, RP, so urea is 15.6, sodium is 141, potassium is 4.8, creatinine 138.8. Then TFT is normal, biomarkers, pro-BNP noted is a raise, more than 25,000. Iron study-wise, iron 5.5, TIBC is 34.2, and total saturation is 18.1. Ferritin level also show 275. So ECG, we noted it's a sinus rhythm with a small QRS complex, Q wave V1 to V4. Then echo-wise, we did on the 25th, noted the EF is reduced 30 to 35%. The left ventricle is mildly dilated. Left ventricular systolic function is moderately slightly impaired as well. The left atrium is mildly dilated, right atrium is mildly enlarged with mild MR and moderate TR. Then subsequently, we did a coronary angiography for this patient. Summarize of this coronary angiography, he got a triple vessel disease with distal left major involvement, main coronary involvement. So then after concluded with all this investigation, age group and echo, the score, then it come to, we count the magic score for this patient with meta-analysis of global group in chronic heart failure to count for the 1 and 3 years of mortality in heart failure. So 1 year, the mortality rate is 8.4%, 3 years is 20.9% in this patient. Then diagnosis we give is a stage 3 heart failure with ischemic dilated cardiomyopathy with coronary artery disease. So for this patient, in our setting, we manage with the fluid restriction. We give a low salt diet, then subsequently for daily weight, and also ensure that it's compliant to the medication. So medication that we're giving in this time, we give the subcut insulatard 6 unit on night, atrapid or the DXT control, then tap spironolactone 12.5 mgod, furosemide, then bisoprolol, empagliflozin, then also cardiopirine corbital gel, and all the atorvastatin and the vitamins for this patient. Subsequently, this patient we counsel for PCI. Currently, she's still in the decision of either doing the PCI. Okay, so this is the case study. So next, I will go into the definition and talk about further management about heart failure. So this is our rough topic that we want to talk about this heart failure today. So for this heart failure is actually a definite abnormal cardiac structure or function leading to an impairment of ventricular filling or ejection of the blood. So it's a clinical syndrome, consists of cardinal signs like breathlessness, ankle swelling, and fatigue that can be accompanied by signs like elevated jugular venous pressure, pulmonary crackles, and peripheral edema. So there's two components of the heart function: is systolic with ejection and diastolic filling. So normally systolic heart failure present with heart failure with reduced ejection fraction, and diastolic wise normally with a preserved ejection fraction due to the reduced filling. So but it can be also affect the left ventricle and also affect right ventricles and both together. So this is the type that we classify into the reduced heart failure, reduced ejection fraction, mild reduced ejection fraction, and preserved ejection fraction. So criteria one, usually patient presented with a symptom and sign. So for reduced ejection fractions, the ejection fraction less than 40%. Mildly reduced is 41 to 49%. With the left ventricular ejection fraction more than 50, that's preserved ejection fraction. But we have to objective evidence of other signs like cardinal structure and also the functional abnormalities considered with the left ventricular diastolic function. Then another one, apart about the right ventricular dysfunction, normally is due to the altering either in the pressure or the volume overload. So this main etiology of this chronic right ventricular failure normally is due to hypertension. So we come into the incident and prevalence. So in developing country, normally the age-adjusted incidence of heart failure may be failing, but presume it reflects a better management of the cardiovascular disease. But due to aging, so overall the incidence are still increasing. So in Europe, the incidence is still 3 per 1,000 person years in all age group, and also 5 per 1,000 person year in adult. Prevalence of the heart failure appear to be 12% in adult, and also with age increasing, so around 1% from those age less than 55 years, and more than 10% increase in those age of 70 years or overall. So in the ESC long-term register in the outpatient setting, the report also mainly they have 60% of them have the reduced ejection fraction heart failure, 24% mildly reduced, then preserved is only 16%. Then more than 50% of these heart failure patients are normally female. So this is the chart that we show that in the higher income place per capacity that contribute the age specific date is lower compared to the low income places. So now come to about the causes. So common causes of the heart failure usually is ischemic heart disease. That's more than 50% of the case we found out the causes. Then hypertension, and also idiopathy, dilated cardiomyopathy, and also WAF disease. So this is the ESC table that show the causes lah. Then example of the presentation and what is a specific investigation they're doing for the to find out the causes. So common is CAD, so hypertension, WAF disease, arrhythmia, then cardiomyopathies, then congenital heart disease, infective causes, drug-induced infiltration storage disorder, pericardial disease, and also metabolic and neuromuscular disease. So presentation-wise, the most common presentation that will come to ED come to our ward is because of the breathlessness, orthopnea, PND, reduced effort tolerance, they came ankle swelling, fatigue, tired. So like typical one, they might come with this confused, depression, palpitation, syncopal, then got nodular cough, bloating sensation. Then sign that usually you can see is the elevated JVP, then hepatojugular reflux. Then sometimes we can hear about the third heart sound like a rhythm, and also there's a displace of the apical impulse. Then others less common one will be have more weight gain, or there's a weight loss when it's in your once heart failure already. Then cardiac murmur, peripheral edema like scotter, then pulmonary crackles, pleural effusion, tachy, then tachypneic, hepatomegaly, shelf stroke respiration, ascites, cold peripheral, and also narrow pulse pressure. Okay, after we talk about the causes, so I come into the pathophysiology of this chronic heart failure. So I mainly talk about this left ventricular systolic dysfunction. So this normally caused by the neurohormonal system. There's a three system. First one is the renin-angiotensin aldosterone system, sympathetic system, and also nitrate uretic peptide system. That subsequently, all this system will cause a ventricular remodeling and result in the symptom like retention, hospitalization, and shorten the lifespan. So first, I want to talk about this activation of renin-angiotensin aldosterone system. So for this system, actually reduce the renal perfusion. Normally, they lead to renin followed by increase in the angiotensin 1 and 2. Then also will increase in the aldosterone level. So increase in this, it will cause vasoconstriction, cause increase in BP, and in the long term, increase after load long term. So also it will increase your myocardial hypertrophy and later cause myocardial fibrosis. Then another way is because increase in aldosterone. So it will lead to salt and water retention. Then when this sympathetic tone is also increased, so the pressure and volume overload of the heart will lead to progressive or the heart failure. So this is a table that illustration the renin-angiotensin aldosterone system that further cause to the hypertension and sodium fluid reabsorption cause the symptom. Then when later we discuss about the management, we can target according all this pathophysiology. The next one is about this sympathetic nervous system overactivity in the heart failure. So SNS system actually it will cause cardiac infarct is to increase the heart rate, increase the cardiac contractility, and also cause peripheral vasoconstriction. So this will mediate imbalance in the baroreceptor reflex and also angiotensin 2 depends on the SNS activation. So it will cause increasing in the noradrenaline and adrenaline. So it will generally increase the vasoconstriction, then increase heart rate and contractility, then also increase in this RAAS activity and also increase the vasopressin level. So for the long term wise, after for this SNS, it will cause down regulation of the beta receptor. Then subsequently also will cause myocyte damage and ischemic, and also might cause ventricular arrhythmia cause of sudden death. So this is the table, the illustration about the sympathetic system. So beside this two system, actually nitric uretic peptide system is a system that feedback mechanism to reduce the ventricular stress. So this nitric uretic peptide system actually they secrete from the atrial and ventricular myocardium in response to the myocardium stress that is from previous two systems. So this system, it will cause vasodilation and also natriuresis and diuresis. So it will reduce blood volume and the PP. and also inhibit the sympathetic activity. So it will cause an action of anti-hypertrophy and anti-fibrotic effect. So, but this nitrate uric peptide in heart failure, normally they're reduced by what the receptor, the nitrate uric peptide receptor C, and also niprolysin. So normally when this level is increased, so we saw is a good markers to diagnose heart failure and prognosis . So this beneficial of this nitrate uric peptide system in chronic heart failure, actually it will deplete and increase removal persistent due to the peripheral resistance. So when management wise, we can use inhibitor so that it will reduce the degradation and promote the beneficial of this effect. Okay. So this is the table that show how by years and by time develop in the depressed and reduced heart failure ejection fraction. So first, when there's an incident event, so the patient will still don't feel any symptom yet that time. So because they still got compensatory mechanism, there's the tree system. So they are trying to compensate and reduce the acute effect. So when longer duration, there's more secondary damage, and this compensatory mechanism fail. So by years and by time, this our heart will eventually increase our cardiac demands and the circulation volume. So it's slowly by year and by time the ejection fraction also reduce with the ventricle remodeling. Subsequently, that will cause all the signs and symptoms that I said, that we have the fluid overload, then angioedema, breathlessness. Okay. So after the pathophysiology, I will go into a classification that I mentioned in the case study just now. So classification of heart failure, we got two. This is one from the AHA, ACCF stage of heart failure, and MIHA functional classification. So for AHA stage of heart failure, A is at risk for heart failure, but without structural heart disease or symptom of heart failure. B, structural heart disease, but without sign or symptom of heart failure. So it's same with the MIHA. There's no limitation in physical activities. Ordinary physical activity does not cause symptom of heart failure. Then stage C, there's a structural heart disease with prior or current symptom of heart failure. So MIHA 1, 2, 3, no limitations, slight limitation in physical activity, and a marked limitation of the physical activity. Then when there's the stage D, so the refractory of heart failure requires specialized intervention. That is when patient is in MIHA type 4 already, but he unable to carry any physical activity without symptom of heart failure or a symptom at heart failure at rest. Just now also in the case study, we mentioned about this Intermax score. So actually this score have 1 to 7 profile. So from 7 to 1 increase in the severity. So the 7 is a 1 NHSA classification functional class 3. So it's a placeholder that patient still can walk more than 100 meters without fatigues and at no reason hospitalization in 6 months. Then 6, there's a walking wound. So means patient still can go out, but it's like having difficulty in doing anything already other than the light activities. Then house bounded means patient can still do daily routines, but limitation activities and hardly to go out. Then number 4 is a frequent flyers. So patient can be weaned from all this support from hospital, temporary discharge, but he may have soon repetitive have to go for hospitalization. Then third one is the dependent stability. So patient still having stable hemodynamic, but patient very difficult to wean off the magnet support with the inotropes. Then number 2 is a progressive decline despite inotrope. So sliding on inotropes. So patient now is dependence on the inotropes and record increment in the dose. Normally this patient is already in the hospital. Then the profile 1 in the Intermax is crush and burn. So means patient hemodynamic is compromised already, hypoperfusion, and need rapid escalation of the IV inotropes. So this Intermax study, normally we use for a patient as a guide that if we need to further plan if patient need for ICT and optional device therapy later. We also mentioned about this MAGIC score, meta-analysis of Goldberg group in the chronic heart failure. So this score is actually for estimate for 1 year and 3 years of mortality rate in heart failure. So there's a table here, show what details that we need about this ejection fraction, recount age, the systolic BP, BMI, creatinine, MIHA class, then gender, is there a smoker, is diabetics, and previously diagnosed with a COPD. Then also if any first symptom diagnosed heart failure in the past 18 months and any use of beta blocker or ACE inhibitor. Beside this, there's a graph that show increasing in the score, show that the mortality is higher lah. In the predict and observation actually is not much difference. So it's basically about this MAGIC score. So next, I'd like to pass to my friend Izam to further talk about the investigation, diagnosis, and the management.
Sorry, everybody can hear me?
Yep, we can hear you now.
Okay, thank you. Okay, so moving on. Now I will explain regarding heart failure approaches to investigation and diagnosis as well as the management. Heart failure management can be divided between acute and chronic heart failures with starting out with chronic heart failures. As explained by my colleague just now, chronic heart failure are classified into three categories, which is heart failure with reduced ejection fraction, heart failure mildly reduced ejection fraction, and heart failure with preserved ejection fraction. Fundamentally, approaches to chronic heart failure are similar among the three types that we mentioned earlier just now. So, and it requires the presence of symptoms and or signs of objective cardiac dysfunction. Following the algorithm, suspicion of heart failure requires three components, which is the risk factors, the symptoms and sign with abnormal ECG, and as follows. The diagnosis of chronic heart failure are made more likely in patients with significant history such as MI, hypertension, chronic artery disease, DM, alcohol misuse, CKD, and so on. So moving into investigation, the following are the diagnostic tests recommended for the assessment of patient with chronic heart failure based on the ESC guidelines. So the first thing is ECG, which may reveal arrhythmias, and the second is measurement of natriuretic peptides, where the BNP is less than 35 and pro-BNP less than 125 will render heart failure unlikely the diagnosis. And moving on to basic routine investigations such as FBC, RP, LFT, and TFT serve as a basis guideline to rule out other or differentiate other conditions as a guide potential therapy as well. Then echocardiography, the key investigation of cardiac function assessment, which determines the ejection fraction where type of heart failure is established, as well as provide information on other parameters. Next is chest X-ray, merely recommended to investigate other causes of surgery and provides supportive evidence of heart failure such as congestion and cardiomegaly. Natriuretic peptides, it serves as an initial diagnostic test to rule out the diagnosis of heart failure. As mentioned, readings of BNP renders heart failure as likely the diagnosis. Do bear in mind that there are numerous causes of elevated natriuretic peptide, which reduces accuracy of diagnosing heart failure, which as guideline and as cardiac and non-cardiac failures. In the ASC guidelines, there are certain recommended tests to determine the underlying etiology of chronic heart failure as summarized in the following tables. Not only that, exercise and pharmacological stress echocardiography may be used for assessment in inducible ischemia in those who are suitable for revascularization. In addition, cardiac magnetic resonance imaging or CMR are recommended diagnostic tool in myocardial characterization for disease such as myocarditis, amyloidosis, sarcoidosis, Chagas disease, and a few other more. So Coming into terms with management of heart failure, pharmacological treatment still serves as a basis for all types of heart failure. Starting with heart failure with reduced ejection fraction, the diagnosis of heart failure with reduced ejection fraction requires the presence of symptoms and or signs of heart failure with reduced ejection fraction where it's less than 40%. Mostly usually obtained by echocardiography. If assessment is not possible by cardiography, then CMR or radial nuclear techniques can be employed. Okay. Treatment goals of pharmacotherapy in heart failure with reduced ejection fraction mainly is reduction in mortality, prevention of recurrent hospitalization, and improvement in clinical status and functional capacity with quality of life. Principles of pharmacotherapy for reduced ejection fraction. These are the four main medications that are being widely used all over the world. ACE inhibitors, ARNI, angiotensin receptor neprilysin inhibitors, beta blockers, mineralocorticoid receptor antagonists, as well as SGLT2. This drug serves as the foundation of pharmacotherapy in patients with heart failure with reduced ejection fraction. Modulation of the ARAS and sympathetic nervous system with ACE inhibitor, ARNI, beta blockers, MRA has been shown to improve survival rate, reduce the risk of hospitalization, and reduce symptoms. The triad of ACE inhibitor, ARNI, beta blockers, MRA are recommended as cornerstone therapies for these patients unless contraindicated and not tolerated. They should be up titrated to the doses used in the clinical trials. These guidelines still recommends the use of ARNI as a replacement for ACE inhibitors in suitable patients who remain symptomatic on ACE inhibitor, beta blockers, as well as MRA. However, ARNI may be considered as first-line therapy instead of ACE inhibitors. The recommended doses of these drugs are shown in the table as mentioned to be uptitrated as per the clinical trials recommendation. Sodium glucose transport inhibitors, dapagliflozin and empagliflozin are added to the therapy to reduce the risk of death and worsening heart failure in patients with heart failure reduced ejection fraction. Recommended for all patients of heart failure with reduced ejection fraction, regardless if they have DM or not. On studies conducted, it is found that SGLT2 causes diuresis with natriuresis. Antihypertensive effect is greater than the thiazide when used in combination of with beta blockers and calcium channel blockers. Improve cardiac energy metabolism, as well as preventing adverse cardiac remodeling and also weight loss. Other drugs recommended to be considered with selected patients in heart failure reduced ejection fractions are diuretics where reduced congestion. However, it does not confer any benefit for long-term outcomes. ARB recommended for patients who could not tolerate ACE inhibitor or ARNI. Study shows that candesartan and valsartan reduce cardiovascular death and heart failure hospitalization. Okay. Ivabradine, F-channel inhibitor at the sinus node, which slows down heart rate and are only effective in patients with sinus rhythm. Reduce the combined endpoint of the mortality and heart failure hospitalization in patients with symptomatic heart failure with reduced ejection fraction with EF less than 35%. Should be avoided in patients with heart rate less than 60 beats per minute, heart block, and decompensated heart failure. Next is combination of hydralazine with isosorbide dinitrate. There are clear evidence to suggest that the use of this fixed dose combination therapy in all patients with heart failure reduced ejection fraction. However, small study conducted showed that this combination compared to conventional therapy reduced mortality and hospitalization in heart failure reduced ejection fraction with New York Heart Association classes 3 to 4. In addition to this combination may be considered in symptomatic patients with heart failure reduced ejection fraction who who cannot tolerate ACE inhibitor, ARNI, and ARBs. But this recommendation is based upon a small study which include only male patients. Next is digoxin. May be considered in patients with heart failure with reduced ejection fraction in sinus rhythm to reduce risk of hospitalization, and the overall effect on mortality with digoxin was neutral based on the trial conducted. In patients with AF with heart failure, most of them had heart failure with reduced ejection fraction. Digoxin may be useful. Digoxin as well has narrowed therapeutic window. Level should be checked aiming for serum digoxin concentration less than 1.2 mil. Caution should be exercised when used on females, elderly, hypokalemic with malnourished patient. Soluble guanylate cyclase stimulator. There was a study assessed the efficacy and safety of the oral soluble guanylate cyclase stimulator, Veriquat, in patients with a reduced EF and recently decompensated chronic heart failure. The evidence of this primary endpoint of death from cardiovascular causes of hospitalization for heart failure was lower among those who received Veriquat than among those who received placebo. 141, there was no reduction in either all-cause or cardiovascular mortality. Thus, Veriquat may be considered in addition to standard therapy for heart failure, reduced ejection fraction to reduce the risk of cardiovascular mortality and hospitalization for heart failure. This medication enhances the activity of HCC, an enzyme in the cardiopulmonary system that relaxes vascular smooth muscle, resulting in pulmonary vasodilation, reduced pH, and improved cardiac output. Soluble guanylate cyclase is activated by nitric oxide released by the vascular inner wall. Nitric oxide binds to the HCC and activates the synthesis of a signaling molecule known as cyclic guanosine monophosphate, which in turn activates a cascade of downstream actions, whereby the function of the CGMP includes irrigation and vascular tone with cardiac contraction and remodeling. Impairment in the function of CGMP pathway can lead to a pulmonary arterial hypertension and heart failure. Its stimulator work in dual ways by directly stimulating HCC and also enhancing HCC sensitivity and nitric oxide. Next is cardiomyosin activator. Study assessed the efficacy and safety of the cardiac myosin activator. The medication omecamtiv mecarbil in heart failure reduced ejection fraction patients enrolling patient in both the inpatient and outpatient settings. The primary endpoint of a first heart failure event or cardiovascular death was reduced by 8%. There was no significant reduction in cardiovascular mortality. But currently this drug is not licensed for use in heart failure. However, in the future may be able to be considered in addition to standard therapy for heart failure, reduced ejection fraction to reduce the risk of cardiovascular mortality and hospitalization for heart failure. It is a new class of myotropes that improve myocardial function by directly augmenting cardiac sarcomere function. The first of this class augments cardiac contractility by selectively binding to cardiac myosin, thus increasing the number of forced generators that can bind to the actin filament and initiate a power stroke at the start of systole. Short-term intravenous administration of omecamtiv mecarbil improved cardiac performance in early clinical studies. So moving on to heart failure with mildly reduced ejection fraction, the diagnosis established as per initial guidelines. It requires the presence of symptoms and signs of heart failure with EF reduced to 40 in between to 41 to 49% with elevated MPs and evidence of structural heart disease. Patients with heart failure with mildly reduced ejection fraction on average features that are more similar to heart failure reduced ejection fraction than preserved ejection fraction, in that they are more commonly men, younger and more likely to have coronary artery disease between 50 to 60% and less likely to have AF and non-cardiac comorbidities. Fundamental treatment for heart failure mildly mildly reduced ejection fraction are quite similar. Medication ACE inhibitors, no specific trials conducted, but may be considered in mildly reduced ejection fraction. ARB as well may be considered, as selected studies on mildly reduced ejection fraction reduce heart failure hospitalization. Beta blockers, similar reduction in cardiovascular hospitalization and all-cause mortality for patients in sinus rhythm with heart failure, reduced ejection fraction and mildly reduced ejection fraction. Other indications such as for AF and angina may be considered. MRA, it reduces hospitalization, but does not cause all mortality may be considered. RD may be considered as well. Next is heart failure with preserved ejection fraction. This guideline has kept nomenclature of heart failure preserved ejection fraction using an EF cutoff of more of 50%, as ejection fraction may not vary not only with sex but also with other factors such as age and ethnicity. Heart failure preserved ejection fraction differs from heart failure with reduced ejection fraction and mildly reduced ejection fraction in that preserved ejection fraction patients are older and more often female. AF, CKD, and non-cardiovascular comorbidities are more common in patients with preserved ejection fraction than those in reduced ejection fraction. Simplified diagnostic approach starts with assessment of pre-test probability. The diagnosis should include the following: the symptoms and signs of heart failure, an ejection fraction of more than 50%, and objective evidence of cardiac structure and of functional abnormalities consistent with the presence of diastolic dysfunction, raised filling pressure, including raised NPs. Well, to date, no treatment has been shown to convincingly reduce mortality and morbidity in patients with preserved ejection fraction, although improvement have been seen for some specific phenotypes of patients within the overall preserved ejection fraction umbrella. However, none of the large RCT conducted in the preserved ejection fraction have achieved their primary endpoints. Absence of recommendation regarding disease-modifying therapies. Treatment should be aimed at reducing symptoms of congestion with diuretics. Reduce body weight and exercise. Identify and treat underlying risk factors, etiology, and coexisting comorbidities in heart failure with preserved ejection fraction. Apart from that, prevention of heart failure, multidisciplinary management of chronic heart failure, patient education with self-care and lifestyle advice, exercise, rehabilitation, and follow-up are the key components in managing heart failure with preserved ejection fraction. Okay. Moving on to acute heart failure, it is a rapid or gradual onset of symptoms with signs of heart failure severe enough for the patient to seek urgent medical attention, leading to an unplanned hospital admission or an ED visit. It may be the first manifestation of heart failure, or more frequently be due to an acute decompensation of chronic heart failure. The diagnostic workup for new onset of heart failure as follows, shown in the algorithm. In addition to the clinical signs and symptoms, workup includes ECG and echo, chest X-ray, lung ultrasound, natriuretic peptides, routine and non-routine blood tests, which includes troponin, which is good for determining ACS, plus TFT with ABG and lactate with VBG to rule out cardiogenic shock, procalcitonin, and pulse oximetry. Patients may present in 4 common types of acute cardiac dysfunction, which are acute decompensated heart failure is the most common form of acute heart failure. About 50 to 70% presentation usually occurs in patients with history of heart failure and previous cardiac dysfunction. Close to the spectrum of left ventricular and may include right ventricular dysfunction. Gradual onset with progressive fluid retention responsible for systemic congestion. Objective of treatment is identification of precipitants, decongestion, and hyperperfusion. Next is acute pulmonary edema, which is related to lung congestion. The clinical criteria are dyspnea, autopnea, respiratory failure with tachypnea. The three therapies should be commenced, which are oxygen support, will be CPAP and IV or HFNC, diuretics and vasodilators, which may be given in systolic BP height to reduce left ventricular afterload. In few cases of advanced heart failure, APO may be associated with low cardiac output. In this case, inotropes, vasopressors, and mechanical circulatory support are indicated to establish organ perfusion. Moving on to isolated right ventricular heart failure. It is associated with increased right ventricular and arterial pressure with systemic congestion. Right ventricular failure may also impair left ventricular filling and ultimately reduce systemic cardiac output. Diuretic often is the first option of therapy for venous congestion. Inotropes are indicated for reduced cardiac output and hemodynamic instability. Next is cardiogenic shock. Primarily, cardiac dysfunction is result as an inadequate cardiac output, which may result in organ failure. Cardiac insult causing severe impairment of cardiac performance may be acute as a result of loss of myocardial tissue or may be progressive as seen in patients with advanced heart failure. Diagnosis mandates signs of hypoperfusion leading to organ dysfunction. Management of cardiogenic shock should start as early as possible as per guidelines showed in the ESC.
Okay, thank you very much to our presenters. Does anyone have any questions for the presenter? Or Dr. Suha, you have any comments or
Yeah, hi, Josiah, can you hear me?
Yes, I can hear you, Dr. Suha.
Okay, excellent. So thank you to Izam and Kelly for a very comprehensive presentation on heart failure. Like I said, heart failure is a huge topic, and in cardiology, you actually have heart failure specialists who are managing these cases. But here we sort of manage all heart failure cases because in Sabah, there are so many patients with heart failure. So I think that, for you guys who are on the front liners, who are seeing the patients maybe for the very first time when they come in, you need to know, number one, acute management of heart failure. I think that is the most important thing. And so when you see a patient presenting with acute heart failure, you want to know what is the cause. So what are the cause? What I like to remember is a mnemonic called CHAMP-IT. CHAMPIT. C is for ACS, coronary syndrome. H is for hypertension. A is for arrhythmias. M is for mechanical cause, such as like your MR, acute MR, any acute AR. P is for pulmonary embolism. I is for infection. And T is for tamponade. So I think that is the first thing that you need to know. Any heart failure patient that you see, you need to find out what is the cause of the heart failure. Then the second step is to touch the patient first, examine and see whether the patient is warm and wet or cold and wet. Because when you touch the patient, you already know, regardless of whether the blood pressure is actually maintained or not, systolic BP, sometimes these patients is like a false sign. So you want to make sure that patient is not cold and wet. If patient is cold and wet, then you want to sort of start some inotropes or something like that, get the infusion furosemide ongoing, start the push and pull regime. You know that this patient is not very stable. So make sure, number one, you need to know their baseline weight as well. You want to make sure that you are diuresing them, you're not over diuresing them. Regular review and touch the patient. I think that it would be very, very important. Then I can highlight some of the causes of heart failure that we're seeing in our patients, patients who are very, very young. Of course, ischemic heart disease is still the number one cause. Then you have your hypertension and your diabetic cardiomyopathy. And then you also have patients with myocarditis now with COVID, or, some other cause. Infection would be one of the causes. And also endocrine causes like thyroid. And there is one more. Yes, here there is a component of drugs and alcohol as well. So those are the top causes. Oh, I forgot. Another thing would be valvular heart. Here there's a lot of patients with chronic rheumatic heart disease and eventually presenting with failure symptoms as well. So that's why whenever, if you can get a bedside echo done just to see how is the EF, how is the valves. Mainly there's only two valves that you're worried about, the mitral valve as well as the aortic valve. So once you've you've established the cause of the heart failure, and then you have established the bedside echo, then you want to know, your friends rightfully pointed out, how is the ejection fraction? Is it mildly reduced? Is it reduced? Because according to the 2021 guidelines, the change has been done there. Less than 40% is all reduced heart failure with reduced ejection fraction. So once it's less than 40%, why are we so concerned about this less than, reduced heart failure ejection fraction? Is because now we have therapies for heart failure. Your 4 pillars of heart failure, those are the most important drugs. And that includes your ACE inhibitors, your beta blockers, your MRAs, and now the most new kid on the block that everyone is excited about, and that is your SGLT2 inhibitor. And your SGLT2 inhibitor, why is it so important? Why is it we are so excited about it? Because it according to trials, the 2 main trials that you need to know about would be the Emperor Reduced trial and then your DAPA-HF trial. Both trials for empagliflozin and dapagliflozin, it's sort of known to reduce the progression of heart failure and reduce the number of hospitalizations for heart failure. And in a patient who is young, like 40-something years old guy with EF less than 40%, I mean, this is going to make a really good therapy for him in long-term progression. So we are trying to sort of diagnose these patients early and start them all on their 4 pillars of therapy. So in most centers now, what they want to do is to start all these 4 therapies inpatient as fast as possible. But of course, in reality, in the real world, maybe we might not be able to, start everything, but at least try. And especially for patients who are motivated, because some patients, to actually get them to comply to so many medications might not always be easy. But at least we can try. Once we have established the diagnosis and, in terms of therapy, this is the line to go, more so than ICD and, all those devices and all that. We have basic medical therapy. And that is what is so exciting about heart failure at the current moment, the ESC guidelines 2021. I think you guys can go through that. Izam has already highlighted some of the algorithms for your heart failure. So if you really need a good reference point, your ESC guidelines is your go-to. And of course, our own CPG for heart failure in 2019. So those would be the 2 references that I'm using on a personal level. And so you guys can have a look at that as well. Of course, to further investigate and all, patients will need an angiogram. Most of them will need an angiogram. And that's where you can refer to cardiology so that we can get the angiogram done. I think the first case that Kelly presented, I'm the one who did the angiogram. And of course, a young Chinese guy, risk factors, and so triple vessel disease, and that is how it goes. Some of them might be still thinking about the PCI and all, but our job is, in the meantime, start with the heart failure therapy. That is something that is important. So there's a lot of information presented today, but just get your head straight in terms of your main causes of heart failure. I think once you have established that, then therapy and the line of treatment is quite straightforward. Yeah, that's all I have to say. Good job to Izam and Kelly.
Thank you, Dr. Suha, for the summary. Are there any questions from anyone from the floor that you'd like to direct to our presenters? Okay, I'll start the ball rolling. Well, I have a question, Dr. Suha. You mentioned that now we'd ideally like to try to start heart failure therapy inpatient as soon as possible. So in terms of timing, for example, ACE, beta blocker, or MRA, after acute heart admission for acute heart failure, how would you decide, okay, now is the time that we should start this? Yeah, in the past, I was taught that as a junior MO when I was in district, I was taught that in acute failure, you cannot give beta blockers, wait till the patient's out of failure. So when is the out of failure moment to start this?
Yeah. So I think those were the days lah. So I was also taught about a similar concept where in acute heart failure, you can't start beta blockers and all that. But from what I'm currently practicing and how Dr. Liu, he's a heart failure expert and he's very passionate about it. So what we do here is once we have managed to initial decongest, the main thing in heart failure is you want to control the heart rate. So for me, even in patients who are the blood pressure systolic is less than 100, but if patient is warm, urine output is good, patient is responding to therapy, I will usually start them off on low dose beta blockers first. That will be my go-to. And then another thing that really complicates matters is when patients have renal failure. So once they have renal failure, then your choices become limited. So, but for me, what I would usually do is I would want to control the heart rate and make sure you get a good heart rate and try. And after a while, once you manage to decongest, the BP will sort of pick up and they will get better. You just need time and patience. So beta blockers first. If the kidney is okay, I'll start ACE inhibitors and then MRA. If the kidneys are not okay, the blood pressure is somewhat borderline, then I will consider beta blockers and SGLT2 inhibitors. And then once the BP improves, go by your ACE and your MRA. So those are the 4 pillars. In Queen 1, you all have SGLT2 inhibitors as well? EMPA and DAPA?
We don't have it readily available. So sometimes
okay.
they call it a referral to the endocrine team or perhaps to cardiology.
Understood. I mean, but I think it's something to think about because that is like a up and coming thing. But of course, in patients who are committed, because cost is always in the back of our minds. And somebody mentioned Entresto, and let's start Entresto for all patients. And but Entresto is again very, very expensive. So in our setting, in a government hospital where we are dealing with massive numbers, I think your basic would be your beta blockers, ACE and MRA, but try for SGLT2 inhibitor as well, if possible. Yeah. So that, and did I answer your question? Beta blockers first. If kidneys are okay, then ACE and MRA, and then if possible, SGLT2.
Okay. How quickly would you titrate out the beta blocker on like every day you double the dose if the BP and the heart rate are okay, or?
Well, some of them, they're very sensitive to beta blockers. I would see first how's the heart rate. If the heart rate is less than 100 with, I'll always start 1.25 slow dose if the systolic BP is less than 100. And if I say that the patient is responding to the initial diuretics, patient is warm, then the next day itself I might increase it to 2.5 because I'm aiming for a very good heart rate. I want to be maintain it between 60 to 80. That is my target. But eventually once you decongest them and all, the heart rate sort of comes down. So I would maintain around 2.5. If it's a difficult patient, then I'll up titrate every day if the BP is permissible and the patient is responding to therapy. So that's what I would do. And if you're having any troubles, I'll always start the push and pull. If the urine output is poor and patient is not responding, then my trick would be I would start push and pull. And dopamine usually 3 mics, and then furosemide either 3 to 5 mics per kg per hour, and then titrate according to urine output and measure the weight and the BP as well. Touch the patient, make sure patient is warm. Yeah.
Thanks, Dr. Suha. One more thing pertaining to that recipe that you prescribed. Would you start and optimize, titrate up to the maximum dose of one agent first before adding the second one, or?
I would say in terms of beta blockers, if I can get a good heart rate, then I'll stop there and add on another agent, because you want to, like your, Kelly mentioned, is it? You have all your pathways and you want to block all your other pathways, right? So I would be more in favor of low doses, but multiple drugs. So like I want to get my ACE inhibitor on board, at least my ACE, because sometimes it's not always easy, Josiah, especially with patients with low blood pressure. And it's in an ideal world, it's nice to start everything, but as many as we can, I think would be the way to go.
Okay, thank you very much, Dr. Suha. Just very briefly, any other questions from anyone from the floor?
You guys, you have a lot of MOs, is this? All these participants?
Yeah, MOs and housemans as well. We invite them to join.
Okay, yeah. So like I said, keep it simple, and as long as we are getting our pathway, always find out what's the cause, and then treatment becomes easier. And then if you guys have any problems, just text me or message me. I'm okay with that.
Okay. Dr. Suha, I have one last question, if no one else has, regarding furosemide. We know, I mean, we've been
wonder drug, but very less appreciated.
So it doesn't seem to improve mortality, but we see most patients with heart failure on some form of furosemide. So is there a time where you would try to should we attempt to taper off the need for furosemide, or it's good to keep patients on the furosemide for long term?
All right. So I know what you're trying to tell me, because sometimes you see the patients back in clinic and then you feel like they are okay, they're very stable, and then they are on low doses furosemide, right? So you want to take whether you want to take them off the furosemide or not. I think if they have come to that point, what I would do is I would go gently, like how I say titrate, meaning EOD maybe, and then see whether patient is okay, and then see back in clinic again, and then go PRN maybe, just give them the furosemide in the event that they if they need it, educate them. If they are good patients, then they will know themselves. But the problem with these chronic heart failure patients is that sometimes it's not always easy to comply to fluids. And some of them, the weather is hot, or, it's not easy for them. So if those patients, I will maintain a low dose furosemide. But if it's other patients where they are good control, they are responding to therapy and all, I would just give them as a PRN basis or a EOD basis, that kind of thing.
Okay, thanks, Dr. Suha.